So hello, everybody. Welcome. For those of you who don't know me, my name is Fleur Wood, and I am the CEO at South Pacific Private. There's lots of familiar faces and lots of new faces. So welcome if I don't know you. Thank you for joining us. This year is a really special year for us at South Pacific. It is our 30th birthday. So we first opened our doors in 1993. So we've been doing lots of events to celebrate that over the last couple of months. It's a huge achievement, something that we're all very proud of here. I'm not going to go too much into the story of how we started, and most of you would know that, and that's probably why you're here, because of that story and that journey. But as the team, we were reflecting on this 30 years and what does it mean to be turning 30, and we talked about the changes. And for those of you who do know South Pacific and are familiar with the work we do here, you know that we were looking at trauma, talking about trauma and abuse right from the beginning, right from 30 years ago, because of the program that was gifted to us by the Meadows. And we were the first people in Australia to be talking about trauma and to be treating it, in a hospital setting. And we were reflecting on the changes that have been made in terms of trauma treatment over 30 years. So while the fundamentals of what we do and the program that was gifted to us by the Meadows hasn't changed, the approach to trauma and the integration of so many new modalities has certainly influenced us and continues to do so. So in my journey with South Pacific, my more recent journey, I've been very lucky to meet Deirdre and get to know Deirdre a little bit. I first met Deirdre, let me just go back to say, in that conversation, we talked about the changes of trauma, and we had this idea to talk to the Meadows about how the changes of trauma over the last 30 years. And I first met Deirdre just shortly after I stepped into South Pacific when Mum passed away in 2019. And I signed up to do post-induction training therapy, which is the modality developed by peer Mellody. I'm sure most of you are familiar with peer's work. And I signed up to do that training. It was during COVID. I was living in New York, and Deirdre was the facilitator, or one of the facilitators for that program. And I started chatting with her. And, as everyone knows, in that amazing coincidence, Deirdre actually did an internship here at South Pacific in 2006. So we had a lot in common, and she'll share a little bit, I'm sure, about her time with us back in 2006. So I did the post-induction training with Deirdre in 2020, and then I did it again in 2021. I loved it so much. And of course, that's the basis and so influential in the work we do here at South Pacific. And then Deirdre and I've stayed in touch since then. And we're really in for a treat today. It's very, very kind of Deirdre to give up her time and come and speak with us. Deirdre has the very fancy title of Vice President of Trauma across all of the Meadows facilities. So not only has she been very, very close to peer and worked very closely to peer and has been peer's right hand and trained with peer for, a decade, Deirdre has also been working very closely with the likes of Peter Levine, Bessel, Kolk, Pat Ogden, Resmaa, Menakem, in integrating those modalities, those more somatically based modalities, and integrating them into peers' work and into the work they do at the Meadows. So we're really excited, Deirdre, to have you here. Really grateful for you taking the time. I know how busy you are. And so I'd like to open the floor to you. Deirdre's going to talk for about 30 minutes. And then we'll open up for a Q&A, and we'll wrap up pretty tightly at 1 o'clock. So I will ask if you can all keep yourselves muted while Deirdre's talking. And then when we come to the Q&A, you can just raise your hand. And I have forgotten to do acknowledgement of country, and I was going to do that right up front. So I apologize to anybody. I'm sorry. I'd just like to acknowledge that South Pacific is on Gay Magal land of the Eora Nation. And I'd like to pay respects to the elders past, present, and future, and that we're very grateful to be on this beautiful healing land. So my apologies for not starting with that. With no further ado, I will hand over to you, Deirdre. Welcome, and thank you again.
Thank you, Fleur, so much for inviting me. It's such a privilege to be here with all of you in this space. I'm really grateful. I'll go ahead and pull up my PowerPoint and just going to talk about the changes in trauma treatment over the last several decades, and also how we're integrating PIA's model with research and neuroscience and somatic experiencing, and then also touched on some of the additions We've made 2 trauma treatment with some of our senior fellows, as Flora had mentioned. So I wanted to start with just, it seems like a long time ago, 1980, and at the time it was a game changer in the trauma field, but post-traumatic stress disorder was added to the Diagnostic Statistical Manual. And, this was excellent at the time, and obviously it didn't capture the full depth of trauma. It was more, more single incident, and trauma is ultimately not about the event, more about what we told ourselves about the event, and also the physiological imprint that it left. But when I was creating this PowerPoint, I was also thinking, 1980, around that time is when Pia started working at the Meadows as the director of nursing, and began noticing that regardless of what addiction someone was coming into treatment with or what mental health condition, there were these underlying themes she was noticing, and began to, put those together in her model, and relational trauma is what was emerging. And her definition of trauma at that time was anything less than nurturing. So I just thought it was interesting, that parallel in time frame. Next, I wanted to mention, just thinking about trauma treatment over the last several decades, Dr. Judith Herman was really instrumental in trauma in the whole field. And I think one of her greatest contributions was just propelling the field more towards brain science and neurobiology. And the other piece too is she gave us the 3 stages of trauma healing, which still hold tremendous depth and weight even all these years later. And ultimately, I think, we talk about the changes in trauma treatment, but we could also talk about, some of the core elements that haven't changed that I think are almost more important than some of the changes. And I think about Dr. Judith Herman, and how her emphatic main idea was that recovery from trauma absolutely had to be within the context of the relationship. And that I still believe that that's at the essence, even today. So the DSM, I just wanted to touch on its limitations and challenges. This manual lists out phenomenology and symptoms, and there's really no underlying organizing principle. And I think that's what's needed is some sort of way to break it out from a neurophysiological standpoint. And an example that I'll give is, if you can have 2 people with the same diagnosis, we'll say post-traumatic stress disorder, and one of them is chronically over-aroused, they're sympathetically dominant and in a constant fight-flight, and the other is chronically in a collapse, shut down, depressed, etc. So you've got 2 diagnoses. You've got 2 individuals with the same diagnosis, yet you're going to treat these 2 individuals very differently. So I think that's important. Just diagnosis matters, because it's going to inform the treatment used. It drives what treatments are approved and covered by insurance, and also where research is going to focus. So I just think that's important to consider. And next, I just wanted to mention, the mid-90s, Dr. Stephen Porges with the polyvagal theory. I think this is also one of the major impacts on trauma treatment. And he studied, how humans manage themselves under threat, and more specifically, how the state of our nervous system and our physiology absolutely will impact how we are experiencing the world, how we take in data, how we create thoughts, emotions, our behavior, what we do, what we don't do. And I always think of, there's that expression, meaning follows physiology, or story follows state. And again, if I'm chronically over-aroused or shut down and collapse, more in a freeze, or if I'm, going back and forth between the two, it's gonna be really difficult for my nervous system to experience relaxation or to allow for a very expansive experience as I navigate through life. If our nervous system is compromised, it makes joy, passion, love, gratitude, these experiences a lot more challenging. So again, the physiology is compromised. That's going to be very problematic. I also wanted to mention world-renowned neuroscientist, Dr. Martin Teicher. I know he's been over to Australia several times. He has done such profound work, and again, just to quickly touch on it, studied how abuse, neglect really changes the brain. Obviously, it's all in the interest of our survival and as an adaptive response, and obviously, unfortunately, creates a lot of negative consequences. But basically, he also studied how different ages were more susceptible to different types of traumas at different ages, and that's so important. For example, if we're bullied at age 13 when peer acceptance is paramount, it's gonna affect us a lot more than if we're bullied as a toddler or latency, potentially. But ultimately, early life experiences shape neural circuitry underlying both physiological bottom-up and personality top-down development. That's like at the core of the neuroscience, I think. Also want to mention, the ACEs study, and really just confirmed, that neurodevelopment is greatly compromised with adversity. And when I think about the ACEs, I think about environmental failure, and I actually think of Pia's model even, because when the environment fails the child doesn't stop loving the parents, the child stops loving themselves. And I always think of that when I think about the ACEs. The other piece with the ACEs is it really illustrated, and the research, how the security and the organization of the self of the child is so threatened with adversity. And the self. Speaking of the self, I wanted to also mention the default mode network, which they identified this in 2000. There's been extensive research ever since, but the default mode network, I think Pia was ahead of her time in a lot of ways. This is her core issue number 3. This is how we create the self, how we organize the self, how we relate to the self, how we relate to the world. And there's a frontal region to the default mode network, and there's a parietal region. It's one of the 3 main networks in the brain: default mode network, salience network, and executive functioning. But why this is important? Well, it's important for many reasons, but there's a lot of studies too, and I just chose one. This study, they had non-traumatized individuals. They sent them through the fMRI scanner. They paused it halfway, and those non-traumatized individuals, when they paused that scanner, those individuals, okay, when I get out of here, I have to go pick up my kid, I have to go grocery shopping. They began that self-reflecting process. And you can see that with the activity that is lit up, anteriorly and posteriorly. And then the bottom 2 images show the traumatized group. When they stopped that scanner midway, there was no self-reflecting happening. There was activity posteriorly, but there was no frontal communication. And, why I think this is important is just clinically, or in terms of trauma treatment and assessment. I think about, so many trauma modalities, based on a PTSD diagnosis, involve dual awareness, where we have, 1 foot in the here and now and 1 foot in the past. And when we look at these scans, it's like you can't travel back in time if you don't have a traveler on board, lest you not do harm. So, and I think, there are, neurofeedback is a modality that intervene, that can reach these deeper regions of the brain. And I don't have the luxury of an fMRI scanner yet, but I believe to the core of my being that, someone using PIA's talking boundary, which to me is the quickest way to access the functional adult, that is probably a bit highly effective at helping to develop the self network. Yep, and just wanted to mention, Bessel, Dr. Bessel van der Kolk and his team in Boston worked so hard to get developmental trauma disorder added into the DSM, and unfortunately it was rejected. But this was so important because developmental trauma disorder really helped to capture the adversity, all the adversity that is not included in the PTSD diagnosis. This is the developmental trauma piece and the relational trauma, and unfortunately it was rejected. And then obviously he went on to write his best-selling book. So I found this, I really appreciated this quote because it kind of illustrates what I just mentioned about, trauma treatment. People who have complex trauma are actually potentially going to react adversely to current standard PTSD treatments, and that's a big part of I think what's happening and is problematic, that I know a lot of us are working to change. Now, with complex trauma, not only do you have the PTSD criterion A symptomology, but then with complex trauma, you've got the 3 additional set of symptoms involving what they call DSO, disturbances in self-organization. So that includes affect regulation challenges, negative self-concept, and the interpersonal, disturbances that happen. And fortunately, complex trauma is making traction. I know the World Health Organization added it to the ICD-11, I think back in 2019. So it's, we're getting there. Now, with neuroscience and the impact on trauma responsive treatment, I just wanted to sort of recap a little bit. So you have early trauma, and the physiological self is compromised, and then the psychological self gets built on this very shaky foundation. And that's ultimately what the neuroscience has confirmed. And then with neuroplasticity, which I think is another great contribution to the field, is that our brain has profound capacity to change. And if we pay attention in different ways, we can reach undifferentiated neural pathways, and this really supports the self-regulation. Also wanted to mention neuroception, which is Dr. Porges's, one of his contributions, that safety is not just the absence of threat. Safety is a physiological state that can be accessed internally, and that we need to, trauma treatment, we really need to support our patients in accessing that neuroceptive capacity so they can feel safe internally, and the social engagement system is a big part of that. We're hardwired for connection, and we need to heal in community with others, and I think that's part of why 12-step is as effective as it is. And then neuromodulation too, I wanted to mention that there's so many devices now that intervene at the brainstem or the limbic system, and they're wonderful. They help to quiet and calm and regulate. But I did want to mention, I don't think they will ever replace the relationship that I mentioned earlier or clinical work. I think potentially it'll make it easier. It makes it easier. And that's about, preserving the clinician as well, which is incredibly important. So again, we've got the systemic dysregulation bottom up, and then the identity distortions top down. And, Bessel emphatic about, identifying interventions that anchor self-regulation and support embodiment. So we're quieting these subcortical regions of the brain so we can reach the executive functioning and, you know, have our patients make much better decisions for themselves. The other pieces with Bessel that I wanted to add, he talks about and emphasizes the importance of interrupting negative feedback loops and pattern responses. And this applies to breath, breathing patterns, thoughts, emotions, sensations, neural pathways, bracing, and other holding patterns in the body. It's and I think, you know, one of the quickest ways we can interrupt negative feedback loops is just even teaching our patients how to breathe diaphragmatically, because then messages, you know, get interrupted from the gut and the heart back up to the brain, that everything is copacetic and you know, there's not the stress response being activated chronically. The other piece is, and I would say he says this more than anything, is promoting interoception and really teaching our patients how to befriend their internal experience and connect to previously disowned parts of themselves. You know, because we can't connect back to ourselves through our mind. It has to be an embodied felt sense experience. And so that's the, you know, when our patients can drop down into the whole of their being, they can access more readily their life force and their vitality. So this is, you know, an important part of the work. And the last piece I wanted to mention regarding Bessel is, again, this is all about the physiology bottom up, but just really supporting shifting from the sympathetic to the parasympathetic. And again, I'm kind of old school, but I have a handheld heart rate coherence device, and I can just look down. I don't need any fancy. I look down. I can see whether I'm in, you know, if it's red, I'm in sympathetic, and if it's blue or green, I know I'm in parasympathetic. And I think if we can, you know I have a colleague who does couples work, and you know, each couple each partner is not allowed to speak unless they're in a sort of a parasympathetic, relaxed, receptive state. But you know, I think when our patients, when we can shift this, they're more receptive, you know, interpersonally, energetically, emotionally, and I think it's us, you know, we as clinicians, ideal to be in that state as well. Okay, I wanted to just provide a real mini case study here to hold. My intention is to kind of tie everything together that I've mentioned thus far. You know, 15 years ago, when I started at the Meadows, average patient was alcoholic with enmeshment. Fast forward to 2023, average patient comes in, has birth trauma, you know, surgery at birth, born blue, cord around the neck, adopted, relinquishment trauma, all have developmental trauma, process, substance addictions, shock trauma, almost with every single one of our patients. Motor vehicle accident, sexual assault, surgery. We had patient recently, it was nowhere in his psych eval, but he had surgery at age 6 to uncross his eyes. And you know, according to Peter Levine, when we're strapped down and our nervous system doesn't know what's happening, it doesn't know the difference between that and an inescapable attack, which, according to, you know, the experts, is the worst type of trauma when the organism thinks death is imminent. So yeah, a lot of stored energy from that surgery. So self-harm and then suicidal ideation. Our patients have experienced some form of racialized, institutional, educational trauma. Basically, you know, a lot of our patients inhabit bodies that have been marginalized by society. Chronic fight, flight, you know, overwhelmed, don't have an observing self on board, and you know, disconnected from self. Stepped out of their authenticity a long time ago. And again, as I mentioned earlier, we don't just have the trauma anymore. We have the additional disturbances of self-organization with the interpersonal disruptions, the self-hatred, and the affect dysregulation. Some of our patients are not internally resourced at all, nor do they have a portable state change skill on board. So it's really about, regulating more so before trying to, do a lot of top down. I included this slide because I think it provides levity to the gravity. And again, as I see patients come in with more levels of internal disorganization, oftentimes they don't know necessarily what they want. And I think this can be in a really important part of the work and exploration. What's in their heart, what's their their greatest longing and desire, and it's typically not behavioral. It's a state ultimately, and with that complex internal disorganization. This is a patient we'll call Emily, and we have a first week mandatory intro to trauma healing where we describe the trauma services we provide and how and why they're being used within the context of their treatment. And this patient wrote, "I need help and I'm not in control of my mind." And this struck me as so profound because, as I just mentioned, our patients are not always able to identify what's most central to them. And yet here she was, to me, just really clearly laying it out there. And this is what that looks like, where, meaning follows physiology. If our amygdala and our fear circuitry is on fire, we are not in control of our mind for the most part. So that, and this is a 60-second snapshot of her brainwaves. So this is a 60-second recording of her brainwaves at rest. And why this is significant is typically we would see the brain waves, the EEG, the electroencephalogram would tend more towards horizontal travel. But if you notice, her has more of a vertical incline. So what this tells us is she is not able to hold a state for 60 seconds. And I think this is important because, when we're assessing in trauma treatment, assessing, which modality is right for which person at which point in time with which presenting issue, it's like, okay, does this person have the capacity to be in the here and now? And in this case, the answer is no, because, presence does have a frequency. So, with that, just the importance of focusing on more bottom up. And again, to kind of bring it all together, it's, it's not bottom up or top down. It's not either or, it's both and. I just think it's critically important that we intervene with both, and we can't regulate self-hatred away, and that needs top down. This is also that same patient, and this is a pre-post snapshot of family of origin workshop. We call it survivors. South Pacific Private calls it changes. The yellow line there, that's beta. Excess beta is clinically correlated with anxiety. And if you notice, her anxiety, her beta totally normalizes, drops way down. This was congruent with her self-report. And this is what that, when the physiology shifts. And I think the most important piece that I hold with this is that Pia's model and her process and all of her interventions are they work not just top down, but bottom up at the same time. And that, I just think that's really extraordinary. The blue line is also another brainwave called alpha. And I'm not going to get too much into it, but I want to just mention here that alpha is what allows us to feel calm in our body, but alert in our mind. And majority of our patients have chronically low alpha, which is a biomarker for addiction. And alcohol and marijuana increase the prevalence of alpha wave activity. So it makes sense given the populations that we're serving. Now, integration, I just wanted to talk for a little bit about, I'm just doing a time check here. This is, just the top modalities, and the ones at the top are more intervening top down, and the ones at the bottom are intervening in deeper regions of the brain. And then the ones in the middle in white are working both, you know, not the either and, but both, either or, but both and. And again, a lot of emphasis in the last couple of years on you know, the bottom up and the self-regulation, and I think that's important. And it's ultimately only one aspect. Now, with developmental trauma, you know, PIA's model is the foundation for treatment across the Meadows. So that's the primary mode of treatment. And I'm biased, but I don't know of a better modality for just clearing out that 0 to 17 family of origin, you know, relational trauma. I just haven't found anything better yet. Shock trauma, we're using somatic experiencing or sensory motor psychotherapy, which is Pat Ogden. We know the research, you know, SE and SP focus on sensation, which is, you know, the language of the brainstem, but it's sensation that is often what gets bypassed with shock trauma. So we're kind of reinstating and laying down that track again by focusing on the sensation. Birth trauma is also another form of shock trauma. We're using SE or, you know, somatic experiencing or sensory motor psychotherapy. Pre-verbal trauma, SE is optimal. Again, you know, oftentimes, like with neglect, it's just that existential dread, that nameless, you know, that existential malaise of, it's oftentimes our patients that have had severe neglect. It's just, you know, it's their implicit sense of things. There's not a narrative there. So, and then with complex trauma, and again, there's assessment tools that you can administer that will tell you, you know, where someone is on the disorganizational spectrum. And what's interesting is the research mentions that as clinicians, we tend to think our patients are more organized than they are, which to me, I find that very interesting, maybe wishful thinking. But with someone who's further along on the disorganization, we're gonna maybe use like something like neuroaffective relational model, because it focuses on identifying an intention, but it also initially will focus on, you know, structuralizing questions versus, you know, structuralizing questions versus processing questions. Because if there's not a strong self-structure and a container to house that processing, an example might be, instead of how do you feel, it might be how are you relating to that. Pia's question of what's the thought that's creating the fear. I mean, that's a very organizing and structuralizing question. Again, I also think, you know, one of the other great changes in trauma treatment is just the research is there, but that healing happens in the here and now. And that, I think, that's pivotal, because, you know, we now know that someone talking about all of their history is not only is it not always helpful, it can actually, you know, re-traumatize, but the importance of, okay, and as you talk about that, what's happening right now, you know, there's that importance of, and again, if people don't have the capacity to be in the here and now, that work needs to happen, obviously, initially. And then just also wanted to mention, specifically with somatic experiencing and PIA's model, they just complement each other so well. But this idea of slowing everything way down, I mean, that's an SE principle, and I think just slowing the process, slowing the everything is so supportive of of just organization. Orienting, I mean, that's a key foundational principle in SE, and it's an intrinsic biological pattern and mechanism that we all have, and it's a brainstem intervention that you can do so readily, just, you know, inviting someone to, you can do it at the group level or individually, but allow, you know, inviting people to connect to their environment through their sensate experience. It's very regulating for the brainstem. And then also just educating, I come upon this a lot, but educating on contraction, expansion, and connection and disconnection. Doing inner child feeling reduction work, for example, that can be very expansive. And we know that if there's an expansion, it's going to be followed by some sort of contraction. And if we can just let them know that that's how the nervous system works, because I know a lot of our patients have a lot of trouble tolerating positive affect. I mean, being okay is very threatening. So, working with that, noticing impulses is another brilliant way that we can weave SE into the model. And, I noticed as you talk about your mother, you're making a fist, and I'm curious if there's an impulse to do anything. And again, just deep, I think it just, SE helps to really deepen Pia's work, working with sensations. And I just also wanted to mention, I have a colleague at the Meadows who, and shared this with Pia many, many times, but wounded child is freeze, and then they adapted as fight, flight. So I always thought that was a very interesting way to conceptualize. Yeah, just beginning to wrap up here, I wanted to also share, I think the trauma-informed movement is, it's non-pathologizing. It's no, we've moved, it's exciting. I mean, we've moved into non-pathologizing, non-reductive, non-regressive, non-cathartic, really, depth-oriented. And I think that's important. And, I don't have the answers. My patient does, and I'm just creating the conditions for healing to occur. Yeah, this I think this is the second to last slide. Pia, I found this in my notes. I've been going through just a million notebooks, but of notes. But your healing presence will ultimately be more important than anything that comes out of your mouth. I love that, and it goes back to that. The relational any modality that doesn't include the relational aspect is, I think, perhaps lacking. But the importance of curiosity, Bessel talks about, curiosity is the antidote to trauma. They can't coexist. And, curiosity is the missing ingredient in healthy attachment. And I also know that the trauma field is also, different aspects of it are getting curious about decolonizing psychotherapy. And part of that is including attachment to nature and our ancestors and the earth, and just that not all attachment is dyadic. And I love that piece as well, and that healing's not linear. And the importance of countertransference, I think, is an unmanaged empathy, and that whole paradoxical idea. It's like the less I am working harder or taking on, the patient's journey, that's actually when I can be more helpful. When I'm not, when there's not emerging at all, that I can be more helpful when I'm not in my therapeutic narcissism and unmanaged empathy. And just also trauma as an unintegrated resource. I think this is such a beautiful, post-traumatic growth, and how trauma can actually bring us to a better place than when we originally, kind of like recovery. We can reach a better place than when we initially experienced the trauma. And then I'm gonna just lastly mention Resmaa Menakem. He's written My Grandmother's Hands. He's healing racialized trauma. He's been training our entire staff, really powerful training, and just is supportive of developing a resilient, embodied, anti-racist culture and philosophy, and that this idea of post-traumatic. There's nothing post about it because it's present, persistent, and pervasive. But the idea that it is structural, and it's not about how one person treats another person. It's systemic. And again, he's an SCP, and he's all about working bodies of culture, working with other bodies of culture to heal, and white bodies working with other white bodies to metabolize the pain and charge, hundreds and obviously hundreds of years of charge that's oftentimes held in the body. And yeah, he also, talks about, dirty pain versus healthy pain and the intergenerational trauma that exists until, someone's willing to feel the pain and metabolize it. And that 9 generations from now, we will have an anti-racist sort of culture is his research and projection. But he talks, obviously we're in the US, but he talks about, everyone who came to the US was running from something. So that, that concept's so powerful, and just trauma and pain that hasn't been metabolized. Okay, I'm gonna pause there, and thank you everyone so much for taking time and being here in this space. I appreciate you.
Thank you, Deirdre. That was really tremendous. Thank you. What an incredible oversight. There was so much there. I've got 1,000 questions personally. I'll be like, I could stay here all night and ask you 1,000 questions, but I would really like to open the floor. I was quite amused at the couples therapist you talked about who had both their clients with their heart math regulator mapping, and they're only allowed to share when they were in a regulated state. What a great tool. I think we've introduced heart math and we're using that in inpatient here. We are, but maybe we'll start bringing it into group more. That was fascinating. Thank you so much. So I will open the floor. If you have a question, please press the raise hand button on the screen, and we'll try and get to as many questions as we can. Anybody, can I see your hands? Has anybody got a question?
I've got mine up.
Great, John. I can't see you. Great, John, go for it.
Okay. Deirdre, welcome and thanks very much. That was, I really like the way you encapsulated in, and it was easy to follow, except I got one, and that's the question I have. DSO, can you just, it was neuroception, you started listing some things for the disorganized. Can you just list that again real quick so I can get that?
Absolutely. It's the complex trauma, which, is the PTSD symptomology plus the 3 additional set of symptoms, which they call it, I think it's the World Health Organization, disturbances in self-organization. That's DSO. But the 3 are affect regulation challenges, negative self-concept, and interpersonal disturbances.
Thank you very much.
Thank you.
And I loved what you said about PSA, well, that the US is running from something. When Pia came here in the 90s, she said that Australia was based in shame, which was quite interesting because people came here, they were sent here because they were bad, and then, the British didn't want them. So she said that they started a colony shame-based. So I like.
Thank you for sharing that. I just got goosebumps.
Thanks.
Thanks, John. Thanks, Deirdre. Someone's just messaged me with a question. Where do you see psychedelic medication in the future of treatment? I mean, that's a whole hour's conversation, but
yeah, it's a great question. I know obviously the research is there. I think it's very case by case, and I know it has to be in the right setting. I know the Meadows doesn't feel like we could do it justice with our various levels of care. I'll be honest, Bessel, the last time I saw him, he said the 2 most powerful modalities are psychedelics and neurofeedback. That's Bessel. And again, I think it's I think it comes down to assessment, which modality is right for which person at which point in time with which presenting issue. I I guess, yeah, I think it will have a place. I think it'll have a place in trauma healing.
Mm.
I mean, I think it already does.
I know one of the things, Deirdre, we've been looking at here is really looking for the studies of the long term, because I'm talking about our psychedelics in relation for addiction, but what I'd like to see is the long term implications. So, person might report feedback that for the next 3 months they were able to manage it, but what's the long term? And I think, we're going to have to wait some time to see how that shows up. Anybody else have some questions? I'm trying to look for the hands up. Anybody else have a question that they wanted to ask? Di, did you have a question?
No, I didn't have a question. I've put my hand up, but I just wanted to say it's great to see you, Deirdre. It was a wonderful presentation. Thank you. And I love that point that John made about Australia, being formed by shame. I think there's a bit of rage covering all that shame, though, I'd have to say, because I think as a country, we were raging against the fact that we were sent here. I have a sense of that too. But thank you for your presentation. It's great. Really like to see you. Good to see you.
Thanks, Di. Dr. Baker? Sorry, you're still on mute.
Do you actually use neurofeedback at SPP?
Sorry, do we do neurofeedback?
Yes.
No, we don't. We don't have neurofeedback at the moment. We're just introducing EMDR. We've introduced heart math, and we're also just about to introduce Stephen Porges' Safe and Sound protocol as well.
So are you interested in introducing your...
Definitely interested. Yes, absolutely. Looking at a way of doing that. Yes.
Okay.
Yeah.
I think I have a solution for you, so I'll speak to you about that later.
That'd be great. Please contact me.
You're welcome.
Francis?
Yeah, thank you. Firstly, thanks, Deirdre. You've got an amazing wealth of experience. Thank you for sharing that with us. I'm not familiar with Pia Mellody's work, actually. So all the other big names, I'm sort of, across those, but not with Pia's. So could you give us a reference of something we could look at that would be a good introduction to her model?
Sure. My first thought is her book, Facing Codependence. Facing Codependence.
Yeah. Okay, thank you.
I know there's also, I don't know the name off the top of my head, but there's so many YouTube videos. I know South Pacific Private has put out many that are an overview of her model that are phenomenal.
Right. Excellent. Thank you.
Yeah.
There's also the training that you do at the Meadows. Do you want to talk a little bit, Deirdre, about some of the professional trainings that you're offering now?
Sure.
Are you still offering PIT training at the moment?
We're actually not. We're not offering it to outside clinicians at the moment. The professional trainings that are happening at Rio Retreat Center, like Resmaa came a couple of months ago for a weekend for professionals. Larry Heller, who created NARM, Peter will come. So we have all of our senior fellows come, and they do like a professionals weekend.
Right. Okay. Well, I'd highly recommend any of the professional trainings at the Meadows. They're really wonderful. The two I've done were really transformative. Do we have any more questions? You might have to just jump in because I can't always see everybody's hands up. Deirdre, I'd like to just ask you a question. If you could talk a little bit more about when working within the window of tolerance and emotional expression with clients, and how, I think one of the changes that we've seen, over since South Pacific first started to now is that role of there was this idea of catharsis being the trauma resolution and the off-pouring of feeling. And now we know that really it's about that expression within a window of tolerance. Could you talk a little more about kind of how you read that in a group setting, how a clinician can work for when a client is both, out of their window of tolerance and yet still that need to grieve and express? Could you talk a little bit about that?
Yeah, that's a great inquiry. I think it's, you know, it's, are they overwhelmed? I define overwhelm as loss of the observing self. So, you know, I think if they no longer have an observing self on board, functional adult, we could use P as terminology, or in NARM, they call it embodied adult consciousness. I think that's when, you know, if we have a sense that they've, you know, gone into a younger place, or they're in overwhelm and they have had that loss of observing self, I think we would want to pause them to check in. You know, and as you asked that, I was thinking about, you know, I think it's important, like we're tracking the somatic narrative, we're tracking, you know, what their words are saying, their cortex. And then I think the third piece is staying in our fifth, like tracking what's happening inside of me. That's that 50-50. And I know for me, I can get a sense somehow when someone has moved out of their window. It's just, it tends to be just in the resonance, where it's almost like that same sort of feeling when there's not a strong sense of self on board. But I think short answer is I would check in with them if I'm in doubt whether they've, you know, moved out of their window of tolerance or their range of resiliency. I might, you know, check in with them.
Right. Yes. There's another question here from Nina T. Does the Meadows have a position on ADHD and perhaps misdiagnosis and/or relationship to trauma and addiction? Where are you at on the ADHD debate?
Yeah, I mean, we're not supportive of treating it with stimulants. You know, if we can support in other ways, but yeah, sometimes attentional deficits are trauma related for sure. And I think doing some of the trauma work and then seeing if the attentional challenges improve, and if not, then I know there's, you know, sometimes there's the non-stimulant directions that our psych providers will. Stratera is one that's coming to mind. I don't want to talk out of my scope of practice.
Sure.
But yeah, I think sometimes it's trauma related and sometimes it's not.
Right. And do you have any means do you assess that when clients are with you? How do you, because, you know, we're certainly seeing a big influx of clients coming to us with an ADHD diagnosis. So working with that, you know, in a treatment facility, and I know clinicians are sharing, they're seeing the same thing in their private practice. And it's complicated when the clients come in very committed to this diagnosis and not knowing how that medication is serving them or causing other issues, particularly when you've got comorbidities of addiction. Yeah.
I think sometimes the best we can do is just start, you know, doing some of the trauma work. And I know with neurofeedback sometimes and other trauma modalities where eventually the meds can be titrated down.
Yeah.
But I think, you know, not to sound so cliche, you know, we have to just work with what's in front of us sometimes. But yeah, I mean, I think it's important to just educate that, because I mean, you know, attention and arousal underlie a lot of these psychiatric diagnoses. So if we can work with the attention and the arousal, you know, quieting, again, doing some quieting of the nervous system, that sometimes the attentional pieces can improve clarity and focus. But sometimes it's obvious. I mean, in group, you know, you could, you know, when it's obvious sometimes when patients are really challenged, just sit still for a little while. And I think it's, yeah, working with that.
Yeah, meeting them where they're at, right?
Yeah.
John, did you have one last question?
Yeah, I did. Linking on to yours, Fleur, Deirdre, this is about the window of tolerance work that Dana Deb does with Stephen Borges, where she helps clients to identify where they are on that ladder, specifically whether they're hyper or hypo aroused, so that they know it helps them in group if you can, get a sense of what's their pattern. I know that Daniel Siegel calls it their temperament. And it's
Yes.
like, what's your temperament when you're triggered around not being safe, sort of thing. Do you guys use her sort of model in looking at that ladder and helping clients to identify their temperament?
We don't use that. I'm familiar with what you're talking about, though, and I think it's excellent. We don't happen to use that, though.
Okay, thanks.
Yeah.
Thanks, John. One more question if anybody has anything. Otherwise, we will wrap up. Annabelle, did you have a question you wanted to ask? Just snuck in there, Annabelle.
Well, I mean, I loved all the integration of the reminder about relationships and that you're using both IFS and EMDR. And personally, I use those together and find clients have, particularly going back to birth trauma and in the womb and even where they were before the womb, an almost psychedelic experience. But I have a really personal inquiry. I'm really curious. What does Pia make of how much IFS has taken off as a therapy? Because it's so similar to her codependency model. Yet it's suddenly like they've got to have a lottery for people to get a place on IFS.
I think she, yeah, I mean, I remember a couple of years ago, her and Dick had lunch together, like at the Meadows. So, and they just kind of talked about some of the similarities and differences. So, I think I remember Pia, I think Pia comes from the place of, there's enough people in the world that need help, and the more offerings, the better.
Yeah.
Abundance. She's all about that abundance piece. And because sometimes IFS will land more, and sometimes Pia's work lands more. It's just, yeah. I do want to say, though, for some of our complex trauma patients, IFS can be further fragmenting. So I do want to name that, because
that's really important. I think it's like any modality that's used in quite a rigid way, that the need, because to me, IFS says, oh, we don't do grounding, we don't do resourcing. And with clients with really complex PTSD, that's just dangerous. So there are others in the IFS world who would really agree with you, like a lady called Joanna Twimbly. I think that's really important. But it's how to it's like anything. People kind of want to hold it too rigidly and inflexibly, but then they're not really in relationship with the client. So it's lovely to hear how central that is to your treatment plan. So thank you for the update.
Yeah.
And Annabelle, what a perfect note to wrap up this hour on. Both that, that was a perfect summation, I think, of our approach to trauma, right, Deirdre? And I do want to acknowledge, I regularly see Pia's work referenced and influencing other people's work. And, she really was a trailblazer. How much we are committed to her in the same way you are. But it is important to see how her work is also being updated and enriched. And again, one of the things I think that was always so impressive with Pia is she always embraced that, didn't she? She was always willing to work with other people and incorporate other modalities. Deirdre, thank you so much. That was a huge learning, and it was an amazing summation. And, I took notes myself. I've got yellow sticky notes all over my desk from what you were sharing in terms of my own personal learnings. And I know things that we will incorporate into our offerings here at South Pacific. So thank you. Gina, did you have one thing you wanted to say?
No, I was just clapping.
Oh, you just clapping.
Say thank you. Yeah.
Thank you.
Thank you.
Thanks, Gina. Thank you, Deirdre, and thank you, everybody, for giving up time out of your busy schedules to join us today. Thank you.
Bye, everyone.
Thank you so much, Deirdre.
Yeah, thank you.